So we're on to the hip now. So instead of breaking up the hip into clinical, imaging, and other, I've broken it down into projection, coronal, axial, and sagittal. I like to get my hips with at least one bilateral snapshot, usually a T1, so I can compare the morphology of the two sides. Then I drill into the symptomatic hip with a small field of view, and I use a series of sequences that I will demonstrate in the first case. The coronal view is a great view for almost every major pathology, including AVN, fractures, labrum, cartilage, gluteus, abductor tears, which are so common and now treated surgically and have been overlooked for so long, bursitis, the ligamentum teres and its two heads, to look for asphericity of the femoral head-neck junction, pistol grip deformity, os acetabuli, the iliotibial band, the tensor fascia lata, and so on. The axial projection. It's a supplementary view for the labrum, both anterior but especially posterior. Gives you a good idea of cup depth and whether the cup is too shallow, as in cam impingement, or too deep, as in pincer impingement. The paraxial allows you to acquire an alpha angle and to see the morphology of the head-neck junction, to see if you have a bump or a cyst or lack of tapering of the femoral head-neck junction. The axial also affords you the ability to see nerves for entrapment neuropathy that might affect the obturator internus space, the genitofemoral nerve, the lateral femoral cutaneous nerve. It allows you to look at the inguinal canal, and then, as mentioned, there are specialized projections that we will discuss, including the axial, oblique, and some radials. Don't forget that there is plenty of anatomy in the neighborhood. There are testes that can be undescended. There's the pubis, there's sports hernias, there's ovaries, there's nodes, there's the iliac fossa, and plenty more. If it's on there, you are responsible for it. The sagittal. Approximately 20 to 30% of all labral tears are only seen on the sagittal because they run from anterior to posterior. So the sagittal view is not an option. It is mandatory for all hip labral assessment. It is also the preferred view to see the inside-out abrasion of the anterosuperior acetabulum in cam-type impingement. It's an excellent view for paralabral cysts, to quantify chondromalacia, to decide whether the patient is a candidate for total hip replacement, for piriformis syndrome with piriformis views, and it shows most optimally gluteus, medius, and minimus tears, which are now repaired, especially in middle-aged women. There are many structures that insert on the greater trochanter of the hip. I've got a little mnemonic here for you, POGOG, which represents the piriformis, the obturator internus, the superior gemellus, the obturator externus, and the inferior gemellus. The gluteus zones of attachment from back to front will be articulated and demonstrated on cases as we move forward. A few other brief comments. Don't forget to look at the ligamentum teres. This is a common cause of hip pain. It's not a serious form of hip pain, but over time it becomes serious as the microinstability proceeds and the hip starts to float out and abut up against the labrum. So loss of the ligamentum teres may be a source of instability leading to labral tears. There's an ischial and a pubic head. We're also going to show you some of the recesses around the hip, and the recesses are a little more prominent up high than they are down low. I think these are better demonstrated on imaging. Labral sulci. This is a source of great confusion. What's a sulcus and what's a tear? I hope to show you case after case after case demonstrating some of the nuanced differences between the two and the supplementary signs that allow you to say, that's symptomatic, that's degenerative, that is a normal variant. The literature, especially the orthopedic literature and the anatomic literature, says that sulci are most conspicuous antero-inferiorly, in the antero-inferior quadrant. But here's another paper that shows you a slightly different descriptor, that 10% of people have a sulcus prominent antero-superior, 12% posterior-inferior, and then so on down the line. So where it is in the clock face isn't necessarily going to get you out of a jam as to whether it's a sulcus or it's a tear. There are going to be other subtle and not so subtle reasons for you to choose one over the other. Roof defects. Roof defects are frequently seen in patients that have impingement. They're usually anterior and superior. Occasionally you'll get a roof defect deep to the cartilage, where there's a very shallow cartilage abrasion, but you can't see the cartilage defect, but you get edema in the subchondral bone. That is not uncommon in people with cam-type impingement. The hip contains plica, normal fibrotic reflections. They can be near the femoral neck, the so-called Weibrecht plica. They can be next to the ligamentum teres. So instead of 2 bundles, you got 3. 2 normal bundles and a plica next to it. Or they can be next to the labrum. So if you have a labrum and a plica sitting next to it, it can look like a flap tear of the labrum. Bursa around the hip. Well, there's the iliopsoas bursa. It's connected to the joint only 15% of the time. There's the obturator bursa. It connects to the joint only 5% of the time. And there are the trochanteric bursa. There's an anterior, a mid superior, or mid or mid superior is the same, and a posterior. Posterior is also known as the gluteus maximus bursa. The mid one, gluteus medius bursa. The anterior one, gluteus minimus bursa, and they sit on various fixed facets of the femur, which you will learn about. They do not communicate with the joint. Bone marrow. Unfortunately, the hip is a place where metastatic disease likes to go. Countless number of times, patients come in with hip pain, and there is an iliopectineal eminence breast carcinoma met. Look at the bone marrow as part of your search pattern. The T1 does fine, but there are bone-sensitive sequences like the Dixon method, A. Dixon, M. Dixon, fat separation, all meaning the same thing, where you have an in-phase image, an out-of-phase image, a fat image, and a water image. You can use that as a supplementary tool without contrast to look for marrow abnormalities. Or if you're scanning at low field or you're time pressed, just get one in-phase and one out-of-phase gradient echo image. There will be special sequences that you use in circumstances that require very fine resolution and detail. And this is especially true when you're looking at the tiny limbus or labrum or thorn of the antero-superior quadrant of the hip. You need small field of view, heavily water-weighted, often 3D images with radial imaging, sagittal imaging, and axial oblique imaging. So when you're chasing labral tears, it becomes more complex. I'm not going to classify labral tears for you right now. They have been classified arthroscopically. There is a radiographic classification, and I don't find this very helpful. What I do find helpful is what we're about to do, which is describe what's a degenerative tear, what's a traumatic tear that's stable, what's a traumatic tear that's unstable, what's a traumatic tear that can be repaired, what's a traumatic tear that requires resection. And with that, let's look at some cases. If you're so inclined, you can certainly look up the Cezerny classification system. So I'm going to start out with my quick bilateral view of the pelvis. It is a 16-year-old. He's a high school runner. He's got persistent hip pain. So let's look at how this study was done. The axials are obtained obliquely along the long axis of the femoral neck through the calcar. Now, if we wanted to measure the alpha angle in this child, we could, because we have the right projection, the axial oblique. So how would we do that? We'd put a point in the middle of the femoral head. We would drag it right down the femur. And then we would say to ourselves, okay, where is the drop-off between the femoral head and neck? Where does it taper? Where's the area of greatest tapering? And granted, there's some subjectivity involved in that decision. But I would put forth that it's here. So I'm going to redraw the line. And I'm going to draw a second line, I'd say right about there. And now I have my angle, which is 35 degrees. What should the angle be? Less than 55 degrees. So this is a normal, tapered, femoral head-neck junction. If it wasn't tapered, if there was a big bump here, or if it was puffy, we'd say there's asphericity. But there isn't. That's not his problem. Let's keep going, shall we? But we do see a little bit of swelling in the medullary bone. Let's take a look at the axial oblique. Not very conspicuous on the T1 weighted image. See what else we have. We have a 2 millimeter axial oblique balanced Sarge, which is basically a balanced, steady-state, free precession image with fat suppression. So it's heavily water-weighted, 2 millimeter slices, 50% overlap. They are chasing a labral tear. You're chasing a fracture, you don't need 2 millimeter images. And the labrum looks terrific. Now what's that? That's a recess. Why is it a recess? Well, let's blow it up. It's pretty smooth. It's got a little curve to the top, and there isn't one scintilla of swelling. Not in the bone, not in the cartilage, nowhere. That's why it's a recess. When we get up all the way to the top, it closes. When we get to the bottom, in my experience, it's a little bit bigger. It's a little bit deeper. In my experience, the recesses tend to deepen as you go down. That is the classic anatomic teaching from years past, and that has been my experience. So let's go to our coronal. How did we obtain our coronal? Let's see if it was a straight coronal or an oblique coronal. It's an oblique coronal. And our oblique coronal shows us the abnormality. An injury to the medullary bone in a runner. The typical location where you get this injury. And they're usually women, and this is a woman. Right there. Right at the insertion of the iliopsoas or right above it. Will you see a little stress fracture or stress injury? There's a little fracture right there. Let's blow it up. That's a problem. And our sulcus, smooth, broad, triangular. Little fluid filling it up. Not a scintilla of swelling in the bone or cartilage. A nice tight capsule, a normal capsule. The relationship of the head to the acetabulum is normal. There's normal coverage. In other words, the drop-off is perfect. The acetabulum is not insufficient. So we don't have any secondary signs of dysplasia. She has a normal tapered neck. She has not a single supportive sign of a labral tear. Only 5 or 6 of which I've mentioned. We're going to hit them all. So no primary signs and certainly no secondary signs. That's how you differentiate a sulcus from a tear. It's round, it's smooth, it's curved, it's symmetric. It may deepen as you go down, no secondary signs, and we have another cause for the patient's problem. So why give them two diseases? So a little bit of common sense, a little bit of morphology, and a lot of knowledge. To finish off the exam, let's take a look at our radial. Here's a sagittal, and here's a radial. So why would we do a radial? To look for a labral tear. So we continuously look at the labrum as we rotate the image. So most of our labral tears are going to be up in here. So we'd be focusing once again on that sulcus-laden area that we saw previously. Let's blow it up. And we use this radial technique for labral pathology in young people all the time. As mentioned, close to 30% of all individuals will have a labral tear only seen on the direct orthogonal sagittal projection. This sagittal was obtained 2 millimeter intervals with a gradient echo, which is a very fine labral sequence. It's good for hyaline cartilage. It's good for fibrocartilage. And then we also performed an adage 2D. This is a 2D adage. This is a 3D adage, so 2 millimeters, 4 millimeters. Both of them gradient echoes. This one showing very nicely the hyaline cartilage and this little bony roof step-off right here. Not a defect. That is where the triradiate segments fuse. That's normal. Ligamentum teres, normal. We had some thinner slices. We could see the two heads. The ischial head in the back and the pubic head in the front. The ligamentum teres is one of the few ligaments in the body that comes from another ligament. So it comes from the transverse ligament up to insert on the fovea capitis. So it's got a ligamentous to ligamentous origin, inserts on bone. Let's look at another one. So that's how you do a hip MR. 15-year-old. Pain following a cross-country run. Okay, we're starting simple. Wow. Is it pain from a cross-country run? Or is it an infiltrative bone disorder? Is it leukemia? Is it an osteogenic sarcoma? Is it other? I'll give you 10 seconds to decide, but only 10. Is the cortex violated? No. It's pretty long, but yet the degree of mass effect is scant. Even the intramedullary space isn't erased. It's relatively preserved. So what are you seeing? Periosteal hemorrhage and bleeding into the surrounding soft tissues. Nothing more. So you might say, well, where's the fracture? Everywhere. Here. Here. There are multiple intramedullary, small, and chondral bone stress fractures with periosteal hemorrhage and soft tissue hemorrhage. This is not a tumor. But when you have diaphyseal disease, you're able to seriously narrow your differential diagnosis. So for you registrars out there, diaphysis, this is one condition you would consider. In fact, you'd make the diagnosis in this case, making sure nobody did something stupid like biopsy it, or do a bone scan, or draw some bloods, come up with the correct answer. But for general diaphyseal disease, you think primary lymphoma, Ewing's, osteomyelitis. We'll stop right there. Softball injury 10 days ago, burning sensation, can't flex. Posterior thigh pain. I'm going to put up my 3 long axis views that are available to me right off the get-go. And once again, there is some marrow signal intensity on the water-weighted image. It's not contentious. It runs up and down, not sideways. There is no soft tissue swelling. So you may simply be seeing a prominent complement of red marrow. Let's keep going, shall we? Now I've put up the short axis views. Patient's age, 40. Pretty good playing softball at 40. So I'll bet everybody's interested in this abnormality posteriorly, aren't you? The T2's on the right, the T1's in the middle. If you were looking at a brain, you would say methemoglobin staining around the outside, not so much on the inside. You might call it a subacute hematoma, and you'd be right. You'd say there's a muscle tear. Then you might have to ask yourself another question. Like, what's going on in the vastus lateralis? What is going on in the vastus lateralis? There's low signal intensity anterolaterally. So we have a subacute hematoma in the back, in the biceps femoris, and a remote ossified, calcified, hemosiderin-laden lesion in the vastus lateralis. So what might do that? He's obviously a very muscular, vigorous, athletic person. He's got almost no body fat. So it could be that he's just a gunner. He's just a tough guy. But you might also have to consider situations that place him at increased risk for muscle tear. And he has one of those situations. He's on Levaquin. He's on a macrolide. And macrolides place you at risk for myotendinous unit tears. He's on Levaquin for sinus disease. It's also true for Cipro. So this is a macrolide-induced series of muscular injuries that occurred in the thigh. Let's look at another one. Got to think like a doc, not like a picture looker. As Bruce Lee used to say, think, feel. Don't just look. I'm going to start out with my bilateral because that's what I always do. I am looking at the amount of coverage of the acetabulum on the femurs. It's a little deficient on the left side. I like to see my labrum and bone right at the femoral head-neck junction drop-off. That's why I like the bilateral. I also like to look at the angle of the acetabular roof. This one's pretty horizontal. If they slope up, I get even more worried. I like to look at the fit of the head in the cup. You know, is it the right fit? Is it conformed? Too deep? Too shallow? I also get a pretty good feel for how the ligamentum teres compare to one another. Now I would say that both acetabuli are a little deficient. They don't go out quite far enough. So most likely this young person has a mild form fruste of developmental dysplasia of the hip. This is one form of developmental dysplasia, under coverage. They don't have to have a roof that slopes all the way up, grotesque, that you would see with the Ortolani maneuver at delivery. They can have low-grade forms of hip dysplasia that lead to other problems like cam impingement. Okay, so we've taken our broad view of the hip morphologically. We've looked at shape. We've looked at cup acetabular conformity and acetabular coverage. We might even hallucinate a little cleft right here, but that might be premature. Let's keep going, shall we? I'm going to keep my bilateral up so I can use it as a reference to see where I am. And I have been given oblique axials. On the right, the T1. In the middle, a proton density with fat suppression, spare, spur, special. 4 millimeter cut, not ideal, but not terrible. I like 2s, 3s, and I like radial 1s. Let's roll. I'm quite interested in this, which looks suspicious for what I described for you earlier, a roof abrasion. Let's go back and look at the alpha angle of this patient. The patient does have a bump at the neck, don't they? Shall we measure it? I don't like to measure things, but unfortunately, I get asked to do this a lot, so I've gotten pretty quick at it. If I can just find the measuring tool. Here it is. Nope. There we go. Thank you. So I bisect the femur. I go right down the middle, equidistant from both sides. And now I pick my first indentation from the top down. And my first indentation is right here. It's the first site of tapering. So my alpha angle is, I think, 69 degrees. What's normal? 55 and below. So elevated alpha angle. Does that mean he's got cam impingement? No, it doesn't. It means he's got a morphology that predisposes him to it. One of your colleagues sent me a beautiful article of orthopedic surgeons and imagers that got together en masse. It's called the Warwick Agreement for femoroacetabular impingement. And they uniformly agreed that you don't make this diagnosis unless you have the morphologic findings and the classic clinical findings, which include pain with hip flexion, pain in the Faber position, flexion, abduction, external rotation, clicking, and some other phenomena we'll discuss later on. So you must have the clinical alongside the morphologic. Otherwise, you're going to overdiagnose people with cam impingement and labral tears. So we do have an abnormal alpha angle. We do have a bump. We have loss of tapering of the femoral head-neck junction. So this term, to summarize these phenomena, is known as asphericity. We also have an abrasion in the anterosuperior acetabulum. We have slight undercoverage, suggesting mild developmental dysplasia of the hip. What about the labrum? Well, this time we have plenty of supplementary signs that would push us more towards a tear than a sulcus. But okay, remember our sulcus? Remember what it did? It didn't go very deep, did it? We make this the labrum. Actually, I'll draw it this way. So our sulcus earlier was slightly triangular and had a conical top to it. But it didn't go very deep into the labrum, and it certainly didn't go through the labrum. Let's look at this one. Whoops, sorry. Trying to blow it up. At first glance, it doesn't look very onerous. It has a little conical top to it. As we go up, it gets a little deeper, doesn't it? It gets more razor-like, more thin, but it's contiguous. As we go down, it gets pretty deep, but it's the up part that's more disconcerting. Let's turn our attention to another projection, because I don't think we can be confident enough yet that this is indeed a labral tear related to impingement. Let's look at our 2 millimeter axial adage. Let's see where we are. I'm challenged. I don't think I can see a labral tear in the anterosuperior quadrant. Here's the marker on the right. You can scroll it with me. Down low, I've got an area of triangular deep signal. So at this point, I'm still voting for a sulcus, even though I think I should have a tear. I'm not there yet. What about my radials? And what about my sagittal? Sagittal, a little challenging. As you get a little medial on the sagittal, there's something right there, but it's the radial that really does it. Right there. Through and through. I'll blow it up for you. How tough is that? That's your tear. Now, it's not round. It's not conical. It took the radial to show this lesion. It's in the mid portion, the mid-medial portion of the hip. It's a pretty atypical position tear, but there's swelling near and around it, and it is through and through. Now I'm showing you one of the hardest ones I have. It's proven. It got arthroscoped and it got repaired. And she has all the secondary signs that support the diagnosis of cam-type impingement. Oh, this is a tough one. So it took the radials to make the diagnosis. Let's look at another. Super challenging.
Number 92092.
And by the way, that chondral abrasion was visible at surgery. Super tough case. Groin pain for 7 months, exacerbated by activity. There's no history of trauma. Patient is 17. I start out with the bilateral. Would you agree that the right hip is slightly undercovered by the acetabulum relative to the left hip? Doesn't quite go out to the drop-off. I think on the right side I should be able to sell you on that. Now this time we have a very kooky angle. Angle should have gone this way. It's more orthogonal. Let's see, perhaps they gave us a correct angle. This one maybe is a little better. Not much better. But that is one weird-looking femoral head-neck junction. Let's go back to the T1. Talk about a bump. That's not a bump, it's a lump. It's so lumpy and bumpy, I can't even figure out where it tapers. I can't even really get an alpha angle on it. So this is asphericity. What else can we spot before we start drilling into the labrum? We've got axial thin 2mm images demonstrating some irregularity of the anterior femur. See that in the coronal. I think that's real. It is real. There's an erosion anteriorly and down low. How about a labral tear? So far, be a tough diagnosis to make. Let's go to our axials and our obliques and our sagittals. Let's go to the radial. I think we got one. We do. Actually, I take it back. Let's go to our sagittal. We've got a sagittal adage, 2 millimeter. Now, labral tears are a little bit strange because anytime a tear runs parallel to the long axis of the labrum, we call it longitudinal. So you can have them longitudinal, horizontal, or longitudinal, vertical, sort of counterintuitive to what you would see in the knee. In the knee, you've got tears that are longitudinal vertical like this, and you've got tears that are longitudinal radial like this. In the hip, anything that runs long axis is considered longitudinal. This is a pretty big tear. Now some of you are saying, what's he talking about? That's the labrum. This is the tear. How easy is that? If you've seen 50 of them, it's pretty easy. Notice that not a single one of these has gotten arthrography. I have weaned every one of my surgeons off hip arthrography. And that was not easy to do. Look at the medial lateral direction and dimension of this tear. We're in tight, looks good. Maybe, definitely, unquestionably, undeniably, still present, still there, maybe not. It's a big tear running from inside to outside. There are secondary erosions on the femoral head, down lower. We've got asphericity. We've got a shallow cup. Look at the depth of that cup compared to the size of that head. We were right. The patient does have DDH. They do have a shallow cup. They do have a bump. They do have asphericity. They do have lack of tapering. They do have a complex labral tear. They do have secondary arthrosis. Let's see if they gave us a radial. I think they did. They did. I hope you're struck by how difficult it is to see the tear on the straight coronal, which is the off go-to sequence. It's there. Remember our sulcus? Not too deep, kind of smooth, not serrated. That's deep. That is not smooth. That's a little bit serrated. So you should have at least been suspicious on your standard T1 4 millimeter water-weighted image. Let's see if the radial added anything. I think this is a radial. It is. Not so much. I'm having a hard time even seeing the tear on the radial, which tells us what? You got to have radials, you got to have sagittals, you got to have axial obliques to avoid arthrography. So this is one of those scans where you have to get a few more sequences than you would like. Cam type impingement. Let's talk about impingement for a minute. Sure. What color would you like? Yellow. So cam versus pincer. So cam, the cup is small. In pincer, the cup is deep. In cam, the neck is fat. In pincer, the neck is thin. In cam, the erosions are anterior. In pincer, The erosions may be anterior, but they are profound posterior. In CAM, there is usually not excessive acetabular retroversion, so deficiency of retroversion. In pincer, there is retroversion. Some of you are saying, well, what's retroversion? We'll talk about that in a moment. In CAM, the abrasions start out anterosuperiorly. In pincer, the abrasions start out postero-inferiorly. In CAM, not a lot of spurs, so spur poor. In pincer, spur rich, big ones. The severity of arthrosis is always worse in pincer impingement than it is in CAM type impingement. Now, because patients with pincer impingement have a deep cup, let's take a look at that cup. Here's the cup. Here's the anterior acetabular wall, mid and posterior wall. And here is our head. So usually the heads are kind of small. Coxa magna, big heads, more commonly seen in CAM impingement. Coxa minor, or coxa minor, seen in pincer type impingement. But if this anterior wall extends out, I need yellow. If it extends out and it forces the femoral head back into a retroverted posture with hip flexion, that erodes the back here and produces innumerable erosions of pincer impingement. So that's why a lot of the arthrosis is in the back in pincer impingement, because the anterior wall of the acetabulum is overdeveloped or hypertrophied. This is known as acetabular retroversion. Generally, I like to see the posterior labrum right at the junction of the bone and the labrum come right into the center of the femoral head, which it doesn't do here because the cup is too deep. By the way, do use the sagittal projection to look at the overall cartilage thickness. The addition of acetabular cartilage and femoral cartilage should add up to about 3 millimeters. Sometimes it's thicker on the acetabular side, sometimes it's thicker on the femoral side, but together it should make up about 3 millimeters. Best way to look at this, high resolution 3D sagittal imaging. You may need to do this to decide on a hip replacement. Buttock pain for 2 years, rule out hamstring injury. Pain has increased in severity following stretching exercises. We have a lot of axials, so let's turn there first. It sounds like a hamstring problem. Give a beautiful look at the hamstring anatomy, the ischial tuberosity is an important way station for innumerable structures, like the adductor magnus and the sacrotuberous ligament. But it is also the takeoff zone for the hamstrings. Now, the hamstring anatomy is a little bit counterintuitive. In the knee, the semimembranosus is medial, right? It's in the medial side of the knee. And where's the biceps femoris? It's in the lateral side of the knee. But in the buttocks, they change places, trading spaces. So the biceps femoris is going to come off medially, and the semimembranosus is going to come off laterally. So the semimembranosus usually has its kind of own origin, and the biceps femoris and semitendinosus come off together conjointly. So this would be the conjoint tendon. This would be the semimem. Sacrotuberous ligament, adductor magnus. None of them are torn. So what's wrong? The patient has edema of the quadratus femoris. So there are two ways you can get that. He could have stretched it and developed an interstitial tear, or while he was stretching, he compressed it, as in ischiofemoral abutment syndrome. So how is that treated? By a physical therapist. And it's going to be the physical therapist's job to figure out whether it was a compressive injury or whether it was a distraction injury. But a beautiful view of the anatomy of the hamstring. Next. So no hamstring tear. So our history is very complex. Right hip pain. Rule out life itself. Patient is 53. Unfortunately, they did not give us a bilateral or a scout. But we can figure out whether these are obliques by looking at our coronal, and they are obliques. So let's put all our axials up at the same time. On the far left, PD spur, 4 millimeters. In the middle, T1. And on the far right, 2 millimeter steady state free precession 3D axials with fat suppression. Now, it's nice to have an orthogonal up to figure out where you are, so I'm going to put one in the middle. And as Michelle and Barack Obama would say, when they go low, we go high. So let's go high, because that's where the tears are. And when we go high, we've got some abnormal signal scattered around the superior acetabulum. Quite a bit of it. Let's blow up our sagittal. Some of that signal is in the bone. Some of that signal is out of the bone. So cystic degeneration, or IOG, in the bone, and pseudocyst formation outside the bone. But look at that labrum. It is macerated. There's a horizontal tear. There's a longitudinal tear running along the long axis of the labrum. It's curly Q. It's kind of scrunched up instead of a nice, well-formed triangle. Game over. You can keep going, and we will, but there is a large labral tear. And these produce groin pain, and our groin pain was commensurate with a labral tear. She also has excessive loss of hyaline cartilage. It's almost bone on bone. So the entire diagnosis, labral tear, bone penetration, abrasion, erosion, cysts, loss of cartilage, is virtually made on the sagittal projection alone. Let's keep going, shall we? Can't hear you. Is there a bump? Haven't gotten there yet. Is there a bump? I'm getting there. Hang with me. Now, that would just be too broad for a sulcus. It's too complex looking, up high. Granted, the sagittal is more informative, but look how deep that signal is. It's almost through and through. I'll allow 50% depth for a sulcus. So that's another criteria. I don't want to see them too deep, and I certainly don't want to see them go all the way through, and they can't make cysts, and they shouldn't be inflamed. So that's a very complex tear. Is there a bump? Let's put up the T1. Not much of one. There's a small one right there. So there is a little bit of asphericity, mild asphericity. We could measure the alpha angle. I can guesstimate it for you. It's probably about 55 to 60 degrees. So right on the border. but that wouldn't influence me one way or the other. What does influence me is the history of groin pain, classic groin pain, that I have a complex labral tear, that I have abrasions, that I have an anterior acetabulum that is too small for the femoral head. I don't have very good coverage anteriorly. So I have a shallow cup for a moderate or normal size to slightly large head. All findings consistent with CAM-type impingement. Let's keep looking, shall we? Let's look at the coronal. Oh, that's impressive. The patient has stripped away the capsule. This is the iliofemoral ligament. You shouldn't have signal running up between this hypointense area and the acetabulum for more than a few millimeters. So there's capsular stripping, and our cyst has dissected through the capsule. So there's a paralabral cyst that is both intracapsular and extracapsular. There's a spur. There's more joint space, narrowing, and early OA. Ligamentum teres, intact. Let's keep looking, shall we? Got a 2D gradient echo. It does a very nice job of showing how severe the cartilage loss is. Probably doesn't do as good a job at showing the labral tear in this case. It does do a very good job at showing the ligamentum teres. And now let's go to the sagittal and the coronal, where this patient does have swelling of the abductors. What are we going to do with that? Well, unfortunately, almost all middle-aged women who are overweight have swelling of the abductors. So when is it important? When they have pain in the abductors. And that pain can be incredibly debilitating. It becomes more important when the pain is associated with a macroscopic tear, as opposed to simple tendinopathy or tendinitis or bursitis, which can be treated with Advil and steroids and goes away very quickly. So let's take a look. Let's go all the way out, see what we got. Now, it's pretty swollen. And I like to break down my gluteus into the main posterior bundle, the middle bundles, an anterior bundle, and then the gluteus minimus. So the best way to look at it is sagittally. Nothing is interrupted. So this is just diffuse confluent tendinopathy. So the conclusion in that case would read moderate osteoarthritis, shallow cup, complex labral tear, mild asphericity, findings consistent with CAM1 impingement. Pain and stiffness, sensation of instability for 9 to 10 months in a 43-year-old male. Now I'm going to let you look at this one for a moment. In the middle, I have put up my MFFE fat suppression sequence. So it's an additive gradient echo fat suppression image with a small field of view, 2mm cuts with 50% overlap. On the far left, T2. On the far right is a T1 with fat suppression. The patient received an arthrographic injection. Didn't need it, but they got it anyway. I'm going to put up one long axis view, and I'm going to pick a coronal for now. It's a rather large man. He's robust. Looks like somebody took a pair of scissors and cut the labrum. It's a labroacetabular junction tear, which is where most of the tears occur. A chondrolabral separation. Easy. You didn't need contrast for that, but they gave it anyway. Why isn't it a sulcus? Doesn't have a round top. It's too deep. It's through and through. It's serrated. Now, I don't like to do just arthrographic studies because then you hide the swelling. So I like to have a pre and a post. But recently, for expediency and for economic reasons, we have stopped doing the pre. But when you stop doing the pre, you do lose the ability to see sites of subtle soft tissue, intra-articular, and skeletal inflammation. So now let's go back to the middle, where we have the mother of all bumps. I could make an alpha angle for you. I probably would draw it right here, and we'd get something like 75 degrees. The patient has a bump cyst complex. Let's go high. Not so easy to see that labral tear up high, is it? On the axial projection. It's easy in the coronal. So now you've seen one on the radial, you've seen one on the sagittal, now you're seeing one that's very easy on the coronal. See if we can cross-reference it. Very tough. There it is right there. There's a tear. It's a little bit more posterior. Let's check out the sagittal on this one. Well, you're parallel to the tear. You're tangent to it. It's right there. You could easily blow right by it. The ones that run from back to front this way, horizontally, they show up better on the sagittal. But the ones that run up and down, especially if they don't have a lot of gap to them, you can cut right by them in the sagittal projection, thus illustrating the need for multi-projectional imaging for labral tears, whether you put contrast in the joint or not. But the better you get, the less you're going to want arthrography. In fact, I find a non-arthrographic hip MR easier to interpret and more accurate than an arthrographic one. So there's our tear, seen on FOSS. There's the T1 weighted image. Tear shows up on the T1 weighted image as well, through and through, so an easy one. What else do we have? Very attritional ligamentum teres. The space is fairly broad, and there's a little fatty hypertrophy, which happens with insufficiency of the ligamentum teres. I'm not sure I have the resolution to say it's ruptured, but I'm confident that it is abnormal. There's another finding in this case. Look at the capsule right there. There's a rent in the capsule. There's just a little bit of the capsule still covering it. So it's a 3/4 thickness tear of the superolateral capsule. You might not have been expecting that. So how would my conclusion read? Posterior-superior labral tear, and I might put it in a clock face. So I would say, antero-superior labral tear. Clock face, most people use 3 o'clock anterior and 9 o'clock posterior. Whatever clock you use, whether you reverse it, 3 in the front, 9 in the back, 9 in the back, 3 in the front, always say what quadrant it's in. So this would be 3 o'clock, this might be 1 o'clock. Or if you went the other way, it'd be 11 o'clock. 11 o'clock or 3 o'clock, antero-superior through and through tear associated with asphericity and a bump cyst complex consistent with cam type impingement and an associated 3/4 thickness rent of the superolateral capsule. Number 2, generalized arthrosis with hyaline cartilage loss, moderate in severity, without bone penetration. Let's look at another. Probably leave the ligamentum teres insufficiency in the body. What a mess. You have a big black hole in the hip. Perhaps they put in a metal-on-metal prosthesis that's made of stainless steel. It's hard to see anything. Who are you going to call? Not Hip Busters. You might call CMAC or Maverick or one of these other specialized, low-profile sequences to minimize the metal artifact, but do not do a gradient echo, or you'll waste your time. Stay with fast spin echo and T1 imaging, and your goals are simple. Look for proteinaceous effusions and see whether they contain particulate material. Let's keep it simple. What type of particulate material? Well, if it's a cemented prosthesis or it's a ceramic, then that particulate material is not going to be metal. It's going to be more intermediate, and it may induce a synovial hypertrophy. On the other hand, if it's metal signal, if it's metal on metal, so-called metallosis, then you will see metallic, susceptibility effect, and very dark signal in the effusion. You should not have an effusion after a hip replacement. And the effusions with these reactions are large, like this one. So let's keep looking, shall we? I'm sure you noticed there was extensive spondylosis in DJD at L4-5 and L5-S1. I'm sure you noticed that there was a tear of the gluteus in the irregular serrated greater tuberosity. This is a plain film sign of abduction failure, this notched effect, well described by our colleagues in Switzerland. I'm sure you noticed that there is a problem with both hamstrings. I'm sure you noticed that the patient has extensive muscular atrophy. But we're more interested in the right hip right now. Let's put up some higher resolution images and see what's inside our collection. So we're going to focus on this collection. So do we see metal, is the question. Now, metal would be really black. And the answer is no, we don't. We see a septum here. We see a body here. We see some gray signal inside. This is what particulate material looks like. It looks like irregular, disorganized synovium, but this is particulate disease, not metallosis disease. The patient has another big problem, a common problem. It's right here. And what is that problem? Heterotopic bone. A lot of heterotopic bone. Medullary bone, cortical bone, there's a piece, there's another piece. It's everywhere. Let's take one final look at both sides. This last image, which is a proton density image using the CMAC technique decreases the metal artifact, but I don't think really adds much to the diagnosis of particulate disease. Gives you less distortion, however. But it does show you that there isn't metal, susceptibility effect, aspect ratio distortion, signal dropout from metallosis. Now, sometimes there's one other thing you can do on the T1 weighted image in these cases. You can look at the edge of the prosthesis and see if there is rarefaction of bone. In other words, gray signal intensity. That would be a sign of prosthesis loosening. MR at the margins is pretty good at this. CT is better. So let's talk a little bit about metallosis, alveol, and particulate disease, which is challenging. By the way, this poor patient has so many problems. You know, heterotopic bone, particulate disease, massive muscular atrophy, bilateral hamstring problems, and look at the abductors. The abductors are virtually non-existent. So this patient is at real risk for subsequent fall and fracture because they have no balancing mechanism at all. And that would be fatal. Let's talk about magnetism. Diamagnetism first. So a small repulsive effect on the magnetic field. In other words, it diminishes the intensity of the magnetic field. Soft tissue, water, nitrogen, copper lining in your scan room are all diamagnetic substances. Paramagnetism. It enhances an attractive force on the magnetic field. In other words, it increases the magnetic moment. This is seen with hemoglobin blood products, oxygen, gadolinium, magnesium. Ferromagnetism. This is when you have a very strong positive magnetic moment with enhanced attractive forces. This is seen with solid iron, iron alloys like stainless steel, cobalt, and nickel. Unfortunately, many hip prostheses contain these substances. Here are examples of weakening of a field from diamagnetism, enhancing the field with paramagnetism, dramatically enhancing the field with ferromagnetism. Prosthetic artifacts are pronounced. They are almost impossible to get rid of. This last sequence that I showed you, the one on the far right on your screen, has a lot less distortion from metal, but it also has, unfortunately, a lot less contrast resolution. This one. So we can see a lot better, but look at how the fat and the muscle and the heterotopic bone and the medullary bone all kind of blend together. So we have made a sacrifice. We've improved the distortion, but we've worsened our contrast resolution and our ability to see into the effusion. So it's a two-edged sword. Now, ferromagnetic effects are most severe in the frequency and slice selecting direction. The least amount of ferromagnetism occurs with titanium prostheses and obviously with ceramic prostheses. Stainless steel is the worst. So it's nice to know going in what type of prosthetic it is, because they may say to you, well, can you help me? Well, what's your hip made of? To the doctor, what type of prosthetic did you put in? Ferromagnetism has a linear relationship with field strength. So you will get a better picture at 0.25 Tesla than you will at 1.5 T in a hip prosthesis case. And you'll still get the answer. Unfortunately, this is Australia, where low field is a crime. At 1.5 T, titanium has a ferromagnetic coefficient of 180, cobalt and chromium 900, and stainless steel 4,000. So stainless steel is tough to deal with. You're going to have artifacts that are in plane, so-called in-plane distortion, where there's signal loss and what's called pile-up artifacts. This can be reduced with fast spin echo or turbo spin echo with long echo times. Sometimes it's helpful to simply switch phase and frequency. Artifacts are the worst when the longest part of the prosthesis is aligned with the magnetic field. Now, the magnetic field usually runs like this, right? You're lying down, and the field goes this way. Your head's over here, your feet's over here. Which way is your hip prosthesis? Same way, right? It's lined with the B0 field. So that makes it even more challenging for you. If you have an open scanner, it's helpful to twist the patient and put them in obliquely, so the stem is not lined up with the B0 field. Also, an open magnet with a vertical field up and down going perpendicular to the stem of the prosthesis could be helpful. Fat suppression. When you're fat suppressing a hip, the best method is stir. Not spur, not spare, not special, not chemsat, stir. If you don't know the difference between a stir and a spur, I'm happy to discuss it with you at the break. I have talked about it here for years. One is frequency selective, the other is non-frequency selective. Stirs are used at high field and specifically at low field because you can't do spur, spare, and special at low field. Geometric distortion. Increased bandwidth limits the spread of geometric distortion. So when you raise the bandwidth, you can decrease the artifact. So now you've got lengthening the TE, going with fast spin echo, going with long echo train lengths, trying to keep the prosthesis out of the long axis of the magnet along its parallel course, the B0 field, and increasing the bandwidth. Through selection distortion. This is kind of counterintuitive. But through selection distortion, along the axis of the prosthesis, is solved, it's not solved, it's improved by thinner slices. So counterintuitively, even though you've got this giant, distorted piece of metal in the body, the thinner the slice, the less distortion you're going to get. So that's another method you can use to improve your overall imaging appearance. There are a number of advanced metal sequences that I have summarized for you here with parameters like MARS, Metal Artifact Reduction Sequence, or WARP used by Siemens, or VAT, or CMAC. And these will all be available and be described for you in detail in MRI Online. The one that's most commonly used is Maverick, and this will also be discussed in detail, but all of these incorporate many of the tenets that we described before, some with extra gradients added in. Field strength. Don't put metal objects for assessment of alval or metallosis in 3 Tesla magnets. You're going to get one big, giant black hole. Stay at 1.5 T or less. There are some little tricks that you can use. If you have to be in a 3 Tesla, I would suggest you stick with T1 imaging and fast spin echo imaging with a high bandwidth, and that's it. Total joint complications. They include metallosis with metal-on-metal prostheses. What does that look like? That looks like fluid with very dark particulate signal inside that is virtually black. Looks like hemosiderin. Particle disease. Just saw an example. Gray amorphous tissue, lots of fluid, but maybe one area has gray amorphous tissue, usually in the back where the particles have settled. Infection. Infection is usually easy. The patients are sick, the effusion is complex, the soft tissues are diffusely swollen. Loosening, that's tough. The T1 is the preferred sequence for loosening. Looking at the margin of the metal and seeing if you have edema or erosive change around the outside, or a little bit of fluid around the margin of the prosthesis. Otherwise, go to CT. Tendon injury. We have it here. We're going to go back and look at it. We have terrible tendon injury in the gluteus medius. In fact, the gluteus medius and minimus are gone. Common. Muscular injury. We have it here. Heterotopic bone. We have it here. Metallosis is associated with something called aseptic lymphocyte-dominated vasculitis-associated lesion. I don't know why they came up with such a long name, ALVAL. We see this in cobalt, chromium, metal-on-metal arthroplasties, and it can be measured by evaluating chromium levels and cobalt levels in the blood. You can do a blood test for it. 17 micrograms for chromium, 19 for cobalt. Aspiration, unreliable. Don't stick a needle in it. Particle disease. This is the body's response to particles of polyethylene from the arthroplasty liner. Unlike metallosis, it is a hypersensitivity response. It is a macrophage-induced disease that leads to osteoclastosis and basically mixed synovial reactions. So you see synovial hypertrophy. The osteolysis comes later. This patient doesn't have it yet, but they will. So this is a prelude to loosening. So our patient has particle disease. They will eventually loosen. They don't have abductors. They have heterotopic bone. And this is not a joint you want to stick a needle in, because then it will get infected. Now let's go back to the case. So admittedly, it's an awful-looking thing. Let's go back to these muscles and the coronal projection. We've already established we've got particle disease. Let's look at our sagittal. Unfortunately, too black to see the, we'll have to look at the muscles in the axial and look at what's left of these muscles, the minimus and the medius. Virtually nothing. And there is no tendinous insertion of the gluteus medius. There's just these small little fibrillated residual fibrils. So there's really not a lot you can do. By the way, the patient has rectus diastasis. Let's look at one more. Probably going to do a little more hip tomorrow, just to start out, because we've got hip is the most difficult joint. And I brought a lot of interesting cases to show you. In fact, I brought a lot of interesting cases for every body part. I'm a little overexcited about it, but that's a good thing. And I'd like to try and make a difference. I'll make this one quick. Another cross-country runner. It's an epidemic of cross-country runners. Left anterior anterolateral sided pain superior to the left iliac crest. Rule out sports hernia. So for sports hernia, I'm interested in the rectus abdominis. It looks fine. There's the linea alba. It looks fine. I'm interested in the adductors, especially their origins. They look fine. Let's put up an axial. I'm interested in looking for defects in the Spigelian line. Fatty infiltration of the anterior musculature. It looks fine. I am interested in the contour of the inguinal canal, the hood, the contents. They look fine. So far, I have not come up with anything that would suggest a soft type of sports hernia. My adductors and pectinei are perfect, but not my pubis. Actually, my pubis is fine. His pubis, not so good. It's a kid, right? cross-country runner. He's only 14. What's he doing with this large edematous pubic capsule? We said the pubic capsule could have some signal in it about 10 millimeters long. This is the entire spate from top to bottom of the pubic capsule, distended, widened. There's the superior pubic ligament, distended. Where's the arcuate ligament? It's present right there, still there. What makes this even more impressive is the bilateral osteoedema in both pubic rami, extending to the ischium. This is what happens in athletic pubalgia. So now that we've established that the ligaments are still there, especially the arcuate or inferior pubic ligament, there's a portion of it. There's the thickened, more posterior portion of it. We need to do one more thing. You might remember from our earlier discussion. We want to check the pre-pubic plate to see if it's coming off the pubis. How might we do that? An axial. Let's get an axial and see if it's flush on there. No fluid in between the pre-pubic plate and the pubis. And then I like to have a sagittal. I don't know if they gave me one. They did. I like to see it very flush on the swollen pubis. And it is not. That's flush. That's not flush. So the prepubic plate is starting to peel from the anterior pubis. So what is the treatment? Rest. Rest usually for 8 to 12 weeks. No weightlifting, no running.